Hey, what's going on, everybody? Today we're going to be talking IBS, Irritable Bowel Syndrome. Now, this is a very commonly diagnosed disease, which is why I really wanted to bring this up today. And it's actually going to be the most commonly diagnosed disease as far as the gastroenterology world, and it's responsible for up to 30% of referrals to GI. Now, IBS is really a pain syndrome. This means we have abdominal pain, and it's going to be accompanied by altered bowel habits, constipation, diarrhea, or a mixture of both. But remember, this is a pain syndrome, so we have to have the abdominal pain. Now, women are really going to be affected at a 2-to-1 ratio, so more commonly affected by women. And as far as age, we don't really know what the average age of this disease is. And the reason being is that a lot of patients suffer for many, many years with IBS before seeking treatment. So we're not quite sure when the average age of onset is, when the peak is, because we just don't have enough data. As far as the pathophysiology, that's not quite understood either. There are a few theories as to why this happens, but really this is a disease or a syndrome of unknown etiology, and it was once believed to be a diagnosis of exclusion. Now, as far as the pathophysiology of IBS, there are going to be 3 main theories as to the implication as to why IBS occurs. This is going to be gastric motility, visceral hypersensitivity, and post-infectious IBS. Now, when we're talking about motility, we know that there's altered motility in patients who suffer from IBS. A specific pattern hasn't been identified just yet, and we're not quite sure of the clinical significance of this altered motility that occurs in irritable bowel syndrome. However, a lot of the medications, a lot of the treatments are geared towards stimulating this gastric motility, and we do know that there are improved patient outcomes when giving these classes of medication. So we do feel like there's a component of gastric motility that's involved in the pathophysiology of IBS. Visceral hypersensitivity. Now, when a patient becomes bloated or we have abdominal distension, we know that certain pain receptors are going to be stimulated, and then pain signals are sent to the brain, causing a sensation of pain. We know that this happens more frequently and more severely when distension occurs more rapidly. So visceral hypersensitivity is thought to be a factor as well. And then post-infection IBS simply means that IBS occurs after infection of the intestine. So after GI infection, we have IBS. There are also going to be other things that are implicated, like genetics, bacteria in the intestine, overgrowth, and fecal flora alterations, food sensitivities, and things of that nature. But again, this is considered to be a syndrome of unknown etiology. What's really important here is to know and to comfort your patient and tell them that this is a chronic disease. But because we have this chronic disease, they are not at risk for developing cancer, and they are not at risk for developing IBD. So we have to make sure that we talk to your patients and we comfort that although this might be painful, this might be discomforting, there's not going to be a shortened lifespan, and there isn't anything serious that they really need to worry about. All right, now let's hit on the signs and symptoms of IBS. Like we said, this is a pain syndrome. This means that we're going to have abdominal pain. Now, the character, severity, and location are really going to vary, but for the most part, we're going to be describing a cramping feeling, and it's going to be localized to the left lower quadrant. Again, this is going to vary with different patients, but this is the most common presentation here. The pain should not be progressive. The pain should not awaken the patient at nighttime. The pain is oftentimes going to get better with defecation, and the pain oftentimes is going to occur after eating. So after the patient eats, we have pain, we have to use the restroom, we use the restroom, and the pain either goes away or the pain gets better. But a lot of times the pain doesn't go away completely, it's just relieved. Like we said, the pain should not be progressive, and it should not awaken the patient at nighttime. If that is true, then we have to look for an alternate diagnosis. It should not be associated with anorexia, weight loss, or malnutrition. If it is, then again, we have to look for an alternate diagnosis. Aside from the pain, we're also going to have altered bowel habits, constipation, diarrhea, or a combination of both. And more often than not, there is going to be a combination of both at some point in the disease process. The diarrhea should not be profuse, and more often than not is going to be associated with a mucus discharge. Half the patients, in fact, are going to describe a mucus discharge, and more often than not is going to be preceded by a sense of urgency. If you notice profuse diarrhea, bloody stools, nocturnal diarrhea, or greasy stools, then again, this should alert you to an alternate diagnosis and should point you away from the diagnosis of IBS. The constipation can last for days to months, and the patients often report a feeling of incomplete evacuation. Now, aside from the altered bowel habits, aside from the pain, oftentimes we're going to notice a sensation of impaired sexual function. We're going to notice dyspareunia. We're going to notice dysmenorrhea. And finally, patients often report a feeling of urinary urgency and urinary frequency. So these are the signs and symptoms of IBS. We have to know that it's a pain syndrome. It's going to be associated with either constipation or diarrhea. Now let's get into the diagnosis of IBS. Now let's get into the diagnosis of IBS. So really we're going to be using the Rome criteria here. But originally the Rome criteria wasn't really useful for diagnosing IBS clinically. It was more so to group patients in similar like fashion. So we wanted same types of patients to have better studies to increase effectiveness and accuracy of these studies. But it's the best we have, and it's really what we're going to be using. So the Rome criteria says that we should have abdominal pain at least 3 days out of the month for at least 3 consecutive months. Now, aside from abdominal pain, we need to have 2 out of the 3 of the following. We need to have improvement with defecation. We need to have a change in stool frequency since the onset. And we need to have a change in stool appearance since the onset. So from those 3 criteria, we only need 2 apart from the abdominal pain that occurs. Symptoms that support IBS are going to be the following. Abnormal stool frequency. These are under 3 bowel movements per week or over 3 bowel movements per day. Secondly, abnormal stool form. So if we have lumpy or hard or loose and watery. Third, if we have defecation that has straining, urgency, or a feeling of incomplete bowel movement. And finally, passing of mucus and bloating. So of these four symptoms are going to support the diagnosis of IBS. Like we said, the Rome criteria isn't perfect, but according to the American Gastroenterological Association, they recommend using a combination of these positive symptoms that are suggested to include IBS, the Rome criteria, with a cost-effective way of excluding an alternate diagnosis. So this means if we have these symptoms that are suggestive of IBS, we use the Rome criteria, we don't have any type of alarm features, and we don't have a family history of cancer or inflammatory bowel disease, then we can more than likely reliably diagnose this as irritable bowel syndrome. Routine imaging isn't really necessary, and if we have all of these already in place, then it's not recommended at all. If we do any other types of imaging or lab testing or stool studies, it's really going to be dependent on if the patient is suffering from constipation or from diarrhea. But like we said, if we fulfilled all these criteria, it's an otherwise healthy adult individual, then we really don't need to do any type of further imaging or lab testing. Further workup really depends on if the patient is suffering from constipation or from diarrhea. Now, if we have diarrhea, we should send the stool out for culture to rule out Giardia. We should do celiac disease screening. We should consider a colonoscopy, and we should also do a 24-hour stool examination. If the patient is suffering from constipation, then we should consider an abdominal x-ray to make sure we don't have any retained stool, and we should also consider a colonoscopy as well. Now we're going to focus on the treatment of IBS, but before we get into specific medication, let's talk about the diet. The diet's going to be an integral part in managing patients with IBS. Whether they have mild to moderate to severe disease, lifestyle changes should definitely be initiated. But the lifestyle changes can be the initial management when dealing with mild to moderate IBS symptoms. Now, we have to really focus and we really have to question the patient and look for certain patterns of food groups. Do certain food groups make symptoms worse, or do they make them better? Does the patient feel no change at all? Patients that identify certain food groups that make IBS symptoms worse, the abdominal pain, the diarrhea, the constipation, we should have these food groups eliminated from their diet altogether. Aside from eliminating these, we should also eliminate gas-producing foods, caffeine, and alcohol. And it's been shown that reducing these things from the diet improves the quality of life in the patient with IBS. Aside from this, we should also implement a low FODMAP diet. We should implement this for 6 to 8 weeks, really cutting out all the food groups on the FODMAP diet. And then once we've done this for 6 to 8 weeks, we can slowly reintroduce certain food groups one by one and see if there's a change in symptoms. But this should really be done by a trained dietitian that knows how to deal with IBS patients, because this can be a little bit complicated. It's definitely intricate, and it definitely takes a lot on the patient's part as well. Now, aside from the low FODMAP diet, there are other things that might be tried empirically if we're noticing that the patient is not improving as we want them to. We can eliminate lactose and gluten from the diet. And we can do this empirically all together and do this universally and see how the patient responds. If they get better, then we continue to eliminate this from their diet. If they notice no change whatsoever, then we can introduce one. And if that seems to be okay, then we can introduce the other one as well. So let's start talking about the medication portion of treatment. The medication is really going to be geared towards helping abdominal pain, constipation, and diarrhea. Let's start with constipation first. Now, first-line treatment for constipation is going to be with polyethylene glycol. This is going to be an osmotic laxative. This is hypertonic and it's really going to draw or pull water into the intestine, helping the patient relieve the constipation. If the polyethylene glycol doesn't work, then we can try adding lubiprostone. Now, the polyethylene glycol is started at 17 grams daily and can be titrated all the way up to 34 grams every single day. Patients with diarrhea predominant symptoms are going to be treated with loperamide, 2 milligrams, 45 minutes before eating. So this is going to be first-line treatment. If the loperamide doesn't work, and what loperamide does is it's going to actually stop the peristalsis, which is going to block the diarrhea from occurring. If the loperamide doesn't work, then we can try bile acid sequestrants like cholestyramine. And the reason why is because half of these patients are going to have bile acid malabsorption, and this is a result, or this actually results in diarrhea. So the bile acid sequestrants like cholestyramine are going to be helpful in predominant diarrhea symptoms. Moving on to the treatment of the abdominal pain, abdominal distension. Here we're going to be using two types of medications. We're going to use the antispasmodics and the antidepressants. Now, the antispasmodics are going to have antimuscarinic and anticholinergic properties. They're going to be given on an as-needed basis every 4 hours. Antidepressant, we're really going to start with a tricyclic antidepressant like amitriptyline. And amitriptyline can be dosed at 25 milligrams every single night. And it's really recommended that we wait 3 to 4 weeks before adjusting the dose because it does take some time to kick in. We have to be aware of amitriptyline side effects like the sleepiness, which is why we dose it at nighttime, and amitriptyline can also cause constipation. Lastly, rifaximin is going to be an antibiotic that's approved for diarrhea predominant as it's going to prevent the overgrowth of intestinal bacteria. Elocitron is going to be a 5-HT3 antagonist. So this is going to be a 5-hydroxytryptamine 3 receptor antagonist, and it's going to be approved for the treatment of severe diarrhea predominant IBS in female patients whose symptoms have lasted for 6 months and who have failed to respond to other conventional treatment plans. This might be beneficial in the diarrhea predominant type IBS patient. All right, guys, so that concludes today's lecture on irritable bowel syndrome.